Hello, good evening. Welcome to the ESGE webinars on Wednesday. And this is our first webinar in 2024. And it's never too late to wish everybody a happy new year, even it's almost January 24th. So good luck, stay healthy. Now, today it's really, I would say, a highlight of our webinars to start with one of the most important webinars I think we have for this year. It's a webinar on a brand new guideline, the Barrett's guideline, diagnosis and management of Barrett's esophagus. And I'm really happy. It's a pleasure to have two excellent speakers here. The first and the last author of this guideline, and it's indeed, I think we have the top experts today here. So the number of registrants were more than 1,000, and we really expect today several hundred participants. So we will have two presentations. First, on diagnosis and later on therapy and management of Barrett neoplasia. And we will have a discussion at the end of both presentations. And please use your Q&A to ask questions. It's a unique chance to ask our experts for the guidelines. And the first speaker is Weusten. I mean, everybody knows him. It's not necessary to introduce a pope of Barrett. So Bas is a very active expert in the field of Barrett. He updated this guideline on Barrett's, and he also initiated the guideline before. He published really a lot of papers in this field, and as said, he is for sure one of the most experts on Barrett's esophagus, and he will speak about diagnosis and surveillance. Everybody knows that he comes from Netherlands, and the Netherlands group are really active in Barrett. So Bas, sometimes I think there is only in Netherlands Barrett's a disease, but I can confirm even in Germany it's an issue. It's a disease which also affects German people, and I'm happy to have you here to give us now the update. What is new? What should the people know for the future? And then later on we have time for discussion. So now the floor is yours. Thank you that you took over the task to give the lecture. It was very, very short, I know, but it's definitely the highlight of one of the webinars this year. Thank you, Bas.
Thank you very much, Helmut, and it's my pleasure to participate in this webinar. Can you see my screen, Helmut?
Yeah.
Okay, great. And thank you very much for the introduction. This is my disclosure slide. And you probably are all aware of the 2017 ESGE position statement on Barrett's esophagus. That was the first paper of the ESGE on the management of Barrett's. And now, as Helmut mentioned, there's a brand new guideline published in the December issue of Endoscopy on the management of Barrett's esophagus. And the first issues I would wish to discuss with you is screening and case finding in Barrett's esophagus. And this recommendation in the current guideline is adapted from the recommendation which was already there in the 2070 position statement paper. And screening and case finding are two separate issues. And screening is in an unselected population, on a population-based screening. And the ESGE recommends against screening for Barrett's esophagus in an unselected population because it's not cost-effective at all. But in an enriched population with a higher prevalence of Barrett's esophagus, ESGE suggests that case finding could be considered. But in what type of patients? Well, that of course has to do with risk factors for Barrett's esophagus, and there are several. And an important risk factor for Barrett's esophagus is the presence of chronic reflux symptoms. On the other hand, it's good to realize that 50 to 60% of all Barrett's cases occur in patients without any GERD symptoms, but nevertheless, it's an important factor to enrich your population for Barrett's cases. So besides chronic reflux symptoms, it's white ethnicity, male sex, obesity, smoking, and a positive family history for Barrett's esophagus or cancer. And the last factor is an important factor as well. So the recommendation is that ESGE suggests that case finding for Barrett's esophagus could be considered in a select population consisting of patients of 50 years of age with a history of chronic GERD symptoms and at least one of these risk factors I mentioned. If you then consider case finding either on an individual basis, if a patient enters your office with a positive family history, for instance, or on a more larger population situation, then you can, of course, choose between endoscopy and other methods. And it is, I think, quite clear that endoscopy for case finding in large populations is probably not cost effective, so there is a recommendation on alternative devices, especially for larger populations. And the recommendation is that the ESGE recommends that a swallowable non-endoscopic cell collection device, such as the cytosponge, combined with setup pathological assessment and biomarkers can be used for case finding in Barrett's esophagus. And you are probably aware of the cytosponge. This is an image of the cytosponge, and it's a sponge which is encapsulated in a capsule, and it's attached to a string. And if you swallow that, then the capsule will dissolve, and then the sponge will pop out. And if you then pull back, you get a nice sample of cells from the esophagus. This cell collection device is quite well studied, and there's most evidence on such devices is on the cytosponge. But there are alternatives. There is the Esophagus, which is more or less a similar device as the cytosponge, but there's also another device which is the ESGE, which is a little bit different, but the principle is the same. You can collect and scrape off cells from the esophageal lining by this balloon with sharp ridges on the surface. But once again, huge bunch of evidence on the cytosponge and much less evidence on the other technologies. Let's move on to diagnosis and surveillance, and mainly surveillance. The guideline has several recommendations on how to perform surveillance, and this was also present in the previous guideline, but slightly adapted. And the ESGE recommends the use of high definition endoscopy, which makes sense. And there's of course not that much evidence for it, but it makes sense to use your best endoscope if you're looking for subtle lesions in the Barrett's esophagus. What about the use of chromendoscopy then? Well, the ESGE suggests the use of chromendoscopy, either dye-based, such as acetic acid, or virtual chromendoscopy for the endoscopic surveillance of Barrett's. And the quality, in fact, is quite low, the quality of evidence, I must say. And therefore, it's a weak recommendation because it's not completely clear if it really is better to do it with chromendoscopy, but there are several factors associated with chromendoscopy which can help in the to raise the quality of surveillance endoscopy for Barrett's esophagus. And one issue here is that for virtual chromendoscopy, mucus, for instance, is a very annoying thing, and it will blur your vision if you use NBI or BLI or eye scan optical enhancement, much more than if you just use high definition white light. So it forces you to do a better cleaning of the esophagus. And that will also help, of course, for the detection of subtle lesions. In addition, if you use chromendoscopy, you will, per definition, take more time to do the diagnostic endoscopy, because you first inspect with high definition endoscopy, and then you will switch on the virtual chromendoscopy, or you use acetic acid, and that will of course lengthen the time you spend in the esophagus, and that makes the likelihood that you detect subtle lesions higher. So therefore it is suggested to use chromendoscopy or virtual chromendoscopy, and virtual chromendoscopy nowadays is available on every endoscopy system, so use it. This recommendation is brand new, and this has to do with standards for Barrett surveillance. And one of the standards defined in this guideline is that there should be a proper photo documentation, not only of the landmarks, which makes sense, the diaphragm pinch, the top of the gastric folds, but also of the entire Barrett segments, including 1 picture per centimeter of Barrett's esophagus. And this is a 5 or 4 or 5 centimeter Barrett's esophagus, and you see nice pictures of each part of the Barrett's esophagus. And then I always try to make almost identical images with virtual chromendoscopy, because that's satisfying as you see nicely corresponding photos. And of course, you should also add photos in the retroflexed position. And in addition to those photos, you should photo document any lesions you detect. And this is an example of a very subtle lesion with white light and with NBI on the lower part of the screen. So you have to do the photo documentation, and you have to describe these lesions using the Paris classification. And of course, you should use the PREG or the CNM classification for the length of the Barrett's esophagus. And after that, you should biopsy visible abnormalities first. So you go first for this tiny little lesion, and then do the random 4-quadrant random biopsies for every 2 centimeters of the length of the Barrett's. This tiny lesion, by the way, was a poorly differentiated cancer. And also new in the guideline is a minimum inspection time of 1 minute per centimeter of Barrett's. And once in a while, you are endoscoping a patient with a very, very, very long Barrett segment, like this example. This was a 20 centimeter length Barrett's segment. And if you then have to spend 1 minute per centimeter, you are already busy for 20 minutes only inspecting these Barrett segments. And if you then add the time for the biopsies you need, then a 15-minute time slot for a Barrett surveillance is simply not enough. It is recommended that you use 30-minute time slots for Barrett surveillance at least, and for these long Barrett segments even longer, 40 to 45, and do it under sedation. All of those recommendations are to increase the yield of Barrett surveillance and to improve the quality of it. A couple of slides on surveillance intervals. The guideline contains a nice flow chart, which is displayed here, and there you can find all recommendations on the Barrett surveillance intervals and what to do if you detect dysplasia. And I will illustrate this flow chart using a couple of cases. I've got 3 cases, and I have got 3 polls associated with these cases, which I like you to answer the questions and to give your votes. So the first case is a 56-year-old male patient undergoing an endoscopy, the first endoscopy, so not known with any disease, an endoscopy for persisting heartburn. And this is what you see. You see nicely the top of the gastric folds over here, and you see a slight irregular part here, maybe a slight extension of this, well, you can call it Barrett's. But it was less than 1 centimeter. It's a 7 millimeters long sort of tongue. So the question I have for you here is what to do if you encounter this patient. And the options are, so what's most appropriate. The options are to do 4-quadrant biopsies, including the tongue, to do a target biopsy from the tongue only, or just ignore everything and do no biopsies at all. And maybe the question can now be opened for your votes. So please fill out one of these options. And I'm curious what you are thinking about this. Should you do biopsies here? Should you do not biopsies at all? So what is your opinion on this case? And this is not a rare situation, you know, because this is quite often if you do an endoscopy for any case of indication. So I think the voting is over now, and now I see the answers. I'm not sure if you can see the answers as well, but 24% voted for option 1, so 4-quadrant biopsies including the tongue, 37 for targeted biopsies of the tongue only, and 39 for no biopsies at all. So this is quite evenly distributed, so it's almost like flipping a coin, I would say. And the correct answer, maybe you can close the, yes, the correct answer here is no biopsies at all, because this is less than 1 centimeter. And if it's less than 1 centimeter, we even don't call it Barrett's esophagus. We call it an irregular Z-line. And there's no indication for doing biopsies here, because we know that even if there's intestinal metaplasia, the risk of cancer is so low that it doesn't justify surveillance, so it's better not to call this Barrett's. And that is also displayed in this flowchart. So we are here, irregular Z-line. I will enlarge it, irregular Z-line or columnar epithelium of less than 1 centimeter, no biopsies, no surveillance. That doesn't mean that you don't need to do a good inspection, because this is also an irregular Z-line, as you can see, but with a very subtle lesion. And you can appreciate it better if I go to the narrowband imaging image here with near focus. This is a subtle lesion, but this was cancer, a T1M3 cancer after removal. So not biopsying doesn't mean don't look well. So you should do a very proper examination of any Z-line, whether it's irregular or not irregular or small tongues or whatever. And if it's really completely normal, then you shouldn't take biopsies. But if you are in doubt, please do. So this is just another way to show you the suggested surveillance intervals. I already mentioned that you shouldn't biopsy and shouldn't survey tongues of cylindrical epithelium less than 1 centimeter. But if it's 1 centimeter or larger but less than 3 centimeters, then the surveillance interval should be every 5 years. If it's in between 3 and 10 centimeters, then the surveillance interval will be 3 years, and Barrett's longer than 10 centimeters should be referred to an expert center because of the relatively high progression rates of these long Barrett segments. There are also stopping criteria, because it doesn't make sense to survey a patient of 90 years old with severe comorbidity, because the likelihood that they will die from esophageal cancer is not that big anymore. So the ESGE suggests that if a patient has reached 75 years of age at the time of the last surveillance endoscopy, and or the life expectancy is less than 5 years, the surveillance should be discontinued, or at least it should be considered to be discontinued. The second case, a 60-year-old male known with the Barrett's esophagus, and this patient is endoscoped for Barrett surveillance purposes. And the Barrett length is C3M4, so 3 centimeter in circumferential extent and 4 centimeters as maximum extent, so the top of the tongues until the top of the gastric folds. And According to the guideline, biopsies were taken, and then the biopsies show that there is low-grade dysplasia. So I've got a second poll, a second question to you. What's most appropriate in this situation? Is it repeat endoscopy after 6 months, revise the biopsies, refer the patient to a Barrett expert center, or to perform RFA? And I hope David can open the poll now. Yes, there it is. So C3M4 Barrett's esophagus, no visible lesions, random biopsies, and your pathologist tells you that in those random biopsies there is low-grade dysplasia. What should you do? Repeat the endoscopy, let the biopsies being revised, or refer the patient to a Barrett expert center, or would you go straight to RFA? Let's see what you all feels about this poll. So the answers are 39% for repeat endoscopy after 6 months and 34% for revision of biopsies. And slightly less participants chose the option of refer a patient to a Barrett expert center, and 8% said, well, you should perform RFA. Well, of course, the answer of this question depends on the setting you are in. But if you are not a recognized Barrett expert center and your pathologist is not a very dedicated pathologist, then revision of the biopsy should be performed. That is the correct answer. Because we know that a community diagnosis of low-grade dysplasia is often downstaged by an expert pathologist. And we also know that if 2 or more expert pathologists agree on the diagnosis of low-grade dysplasia, that the risk of progression of those patients increases significantly. And if the Barrett expert pathologist judges the biopsies as non-dysplastic in the revision of the biopsies, then the risk of progression of those patients are similar to non-dysplastic Barrett's. So before you embark in RFA or refer the patient, it's easier and probably cost-effective to send the biopsies to an expert pathologist and ask for a second reading of the pathology slides. And that is also mentioned in this flowchart here, and I will zoom in here. So the 4 quadrant random biopsies, dysplasia, it should be confirmed by a second experienced pathologist. And if there is confirmed low-grade dysplasia, that would be the moment to send the patient to a Barrett expert center. And if not, then the patient will enter into the regular surveillance endoscopy intervals. So this is my final poll, my final case, before I hand over the microphone back to or to Roos or to Helmut. So this is an 80 years old male patient. So an old patient with endoscopy for heartburn and mild dysphagia. And this is what you see. A reflux esophagitis grade C. And this is in more detail. So my question to you is, what is most appropriate here? So reflux esophagitis grade C. Take biopsies. Double the PPI dose or put them on double dose PPI and repeat endoscopy after 6 to 8 weeks. Or dilate, double the dose of PPI or put them on double dose PPI and repeat endoscopy at 6 to 8 weeks. Or do you say, well, this is an 80-year-old male patient, dilate, double dose PPI and taper the dose at 8 weeks and don't do a repeat endoscopy because he's 80 years of age. So what would be your vote in this 80-year-old patient with this endoscopic images with reflux esophagitis grade C? You can see it's a little bit stenotic there at the top image because of the reflux esophagitis. So the answers are: take biopsies in 10% and put them on double dose PPI, repeat endoscopy at 6 to 8 weeks. The vast majority of votings were on that option, 74%. And a few were in favor of the option of dilate first and put them on double dose PPI. And 5% said, well, dilate patient and send him home and do not perform a repeat endoscopy. The problem here is, and this is a real case, it happened a couple of weeks ago in our hospital, that this is a case which isn't just a simple esophagitis. The correct answer here is take biopsies, because it was judged to be an esophagitis. But if you do a careful inspection here, it is not only esophagitis. And that is displayed in this part of the flow chart here. So reflux esophagitis grade C or D means that you should search for visible lesions. And only if you don't see a visible lesion, don't see a suspected area, then you should optimize anti-reflux therapy for at least 6 weeks and do the repeat the endoscopy. But if you see something which is, which makes you in doubt whether that's normal esophagitis, then you should take biopsies. And it should be emphasized that's not seldomly a superficial or a flat tumor has some debris mimicking esophagitis, such as in this patient. This is not esophagitis. This is mucus and cell debris on a circumferential cancer. Well, and after having said that, that was the end of my presentation, and I'm very happy to handle over the microphone back to Helmut.
Thank you, Bas, for this really excellent presentation and your very lively presentation of cases, which makes really sense to understand guidelines in these cases. So I think there are a couple of questions from the Q&A, but we will discuss it later on. And I think we've now continue with the next presentation, and this will be Roos Pouw. She is also from Netherlands. So I said in the very beginning, the experts for Barrett's come from Netherlands, but no worries. I think there are many experts in Europe for this disease. Roos is really well known for her research in the field of Barrett's, and she is for the moment doing a lot of trials where we are also participating. Roos, I think you will present the topics on how now to manage Barrett neoplasia. What is the new recommendation of the guidelines? Where are the problems? And I think we can discuss it afterwards. So for now, I think thank you for also taking the opportunity so very shortly to give this lecture. I know it was just one week ago, and I'm really happy to have the last and the first author of our guidelines here and present now the brand new guideline. Roos, now please, it's yours.
Thank you very much, Helmut. So I have like a 50% German gene pool, so it's a little bit better. It's not just a Dutch disease. So thank you very much for the invitation. Although it was short notice, it's always a very nice topic to talk about, and we had a really nice group of people working on this guideline. So it was actually a pleasure to work on it, also together with Bas, of course, and to have the opportunity to present some of the highlights, I think, from the guideline. So just start with my disclosure slides and then continue to the first question. So as said, we had so Bas and I didn't have much time to align presentations, so there might be a little bit overlap at the beginning, but I don't think that's a big problem. It's actually just also to test if you all have been paying attention. Because this is also a case of a patient with low-grade dysplasia. It's a fit and healthy or vital 72-year-old man. And this is the image from the surveillance endoscopy he had. It was a C4 M5 Barrett esophagus. There were no visible lesions. Biopsies were obtained, and those showed multifocal low-grade dysplasia at this biopsy or at this endoscopy. And then the question here is, endoscopy in 6 months, review by an experienced pathologist, do ESD of the Barrett segment to prevent progression to cancer, or try to do that by ablation. So this is again a poll, which we are putting up. I'm very curious what the answers will be, of course. The choices were a little bit comparable to Bas's presentation, so. Excellent. Yeah, so I think just to keep this on here, I think actually Bas explained really nicely that review by an experienced pathologist is really important. So if that's really not possible, or you have an expert pathologist in your center, then indeed endoscopy in 6 months would be recommended. Of course, optimize PPI treatment in these patients. ESD of this segment, if there are no visible lesions, really don't do it. The patients will end up with an ugly stricture for actually a benign disease. So I really would recommend against that. If you would do some kind of ablation, do that with other techniques, but we will get back to that. So we can close the poll and then I'll continue. So one of the recommendations we had in our guideline is that you should offer endoscopic eradication therapy with ablation, so not resection, to patients with Barrett's and low-grade dysplasia on at least 2 separate endoscopies, both confirmed by a second experienced pathologist. So I think the most important things here is the ablation and not resection, and that you should have the low-grade at 2 separate endoscopies, because we know that that's a risk factor for progression. Multifocal disease at 1 endoscopy is not per se a risk factor for progression, but having it at separate endoscopies is, and also the fact that it's confirmed by a second pathologist. And we also know from studies that if you have patients with low-grade dysplasia at one occasion, and you follow these patients, that in some patients, about a third, you may not find it in the future again. And then if you would treat these patients, you would over-treat them, and treatment is never without risks. And this is a little bit to illustrate what was discussed. So this is a study from one of my colleagues in which 264 cases of low-grade dysplasia from a community setting were reviewed by an expert panel of pathologists. So the majority were downstaged to no dysplasia. Some were called indefinite for dysplasia, and only about a third was confirmed to have low-grade dysplasia. And this is just really a difficult diagnosis for most pathologists, because in Barrett's, there often is coinciding inflammation, and those changes may mimic true dysplastic changes. So to really be able to recognize true low-grade dysplasia takes practice and experience. And the interesting thing is that if you follow these patients, in this case for 39 months, then indeed the cases that had no dysplasia or indefinite for dysplasia had a low risk of progression. But the patients with true low-grade dysplasia confirmed by an expert or experienced pathologist had a significant risk of progressing of 9% per patient per year. And this is data from a study from the US from 2009, one of the first big landmark studies on radiofrequency ablation, in which they included patients with low-grade dysplasia and high-grade dysplasia. And when we focus on the patients with low-grade dysplasia, they were randomized to either ablation or sham treatment. And the interesting thing is that when you look at the results, there was really a significant difference in the number of patients who progressed to high-grade dysplasia or cancer. In the middle, you see the blue and the red bar for the low-grade dysplasia cases. And you see that in the low-grade dysplasia arm, in the patients who were treated with RFA, the risk of progressing was about 5%, where it was almost 16% in the patients who had the sham, so no treatment. In Europe, we also did a randomized study in patients with low-grade dysplasia. So this was a study in 9 European hospitals in which we included Barrett esophagus patients who had at least one diagnosis of confirmed low-grade dysplasia. They were randomized to surveillance according to the guidelines or eradication therapy with radiofrequency ablation, and the outcomes were progression to high-grade dysplasia or cancer. In this study, we also found that there was a significant difference in the number of patients progressing in the surveillance arm, 18 patients, compared to only 1 patient in the RFA arm after 3 years. So the study was prematurely stopped because of superiority of RFA. And also on the long term, we added additional follow-up. You see that this result and progression-free survival is still higher in the patients who had RFA treatment compared to the patients who had no treatment. So if you have 2 confirmed diagnoses of low-grade dysplasia, you can discuss endoscopic eradication therapy versus surveillance, also because the treatment we have, the ablation, is safe and very effective. But it is still, and I like to stress this always, ablation is still, it's a prophylactic treatment to prevent progression to high-grade dysplasia or cancer. So don't just treat everybody, but really consider patient's age, life expectancy, and also the patient's preference. Because as said, RFA, it's very safe, but some patients do develop a stricture or have a lot of pain, and that might not be worth it if they don't have that much longer to live, for example. So really consider everything before you start treating these patients. And I also think, as Bas nicely showed, that nowadays we have a very good endoscopy system. So if you have these patients under strict surveillance, you will also be able to detect any visible lesions at a still curable stage. So that's the low-grade dysplasia part of the guideline. Then we move on to high-grade dysplasia. So in the guideline, we recommend endoscopic ablation treatment for Barrett's with confirmed high-grade dysplasia without visible lesions to prevent progression to invasive cancer. So actually the risk of progressing from flat high-grade dysplasia to cancer is not very clear. There's not a lot of very good data on it. Most data is a bit older. We assume that the risk is about 6.6 per 100 patient years, but most studies are quite old. And we know that if you compare endoscopy, even from 10 years ago to endoscopy nowadays, the definition of flat Barrett's is really different because nowadays we pick up much more subtle lesions. And what was called flat high-grade dysplasia 10 or 20 years ago might have been a cancer that was not recognized as such. So we don't have very good data on this like we have for, or better data as we have for low-grade dysplasia. But we do know that there is an increased risk. And there are 2 randomized trials in patients who have flat high-grade dysplasia in a Barrett's esophagus. One of them is the trial I already showed you, the AIM dysplasia trial from the US, in which the patients were randomized to a sham treatment or RFA. And also in the group of patients with high-grade dysplasia at baseline, you see that there's a significant difference in progression when you compare the patients who had sham treatment in red to the patient who had RFA in the blue bar. There's also one study on photodynamic therapy, which we don't use anymore because of the complication rate. But this was actually a nice study in which 138 patients were treated with PDT and 70 were randomized to PPI treatment only. And in this study, they also found a significant difference in progression to cancer in the patients who had PDT compared to the patients who had PPI only. And also after 5-year follow-up, this significant difference was still found. And because we have tools nowadays that are very effective in eradicating Barrett's esophagus with a very low complication rate, we have advised that for patients with high-grade dysplasia, to treat them with endoscopic eradication therapy to really prevent progression to cancer. But that's only in the cases without visible lesions. So what do you do if you have a visible lesion in a Barrett segment? Well, I think the guideline is very clear on that. If you have a visible lesion, endoscopic resection is always the first step. It's not only therapy because you remove the lesion, but also very important that it allows for optimal histological staging and risk differentiation, stratification, so you can decide on the best further treatment for the patient. And this brings me to my second question. So this lesion, which you see here, removed with a piecemeal EMR in 2 pieces, and histology showed a moderately differentiated adenocarcinoma with submucosal invasion up to 400 microns in the submucosa, without lymphovascular invasion, and it was a R0 resection. So what would you do next? Would you refer the patient for surgery because there's submucosal invasion? Would you offer the patient eradication therapy for the remainder of his Barrett's? Would you perform oncological staging, or refer the patient for chemotherapy because the lesion is gone, but it was a high-risk lesion? So if you can put up the poll, I would be interested in what you would offer or how you are treating such patients at the moment. So I will not discuss ESD versus EMR during my talk. There's a very nice ESGE guideline on that topic. In this case, I used the piecemeal EMR because it was a flat type lesion. And I'm very curious what you're all voting at the moment. Yeah, so I think 14% would refer the patient for surgery. Some 2% would refer the patient for chemotherapy. And then there's about 40-40 who would offer endoscopic eradication therapy or perform oncological staging. Good, so we can close the poll, and then I can move on to the next slide. So I said EMR or ESD is really, it's a cornerstone of endoscopic treatment of Barrett's. So if you treat patients or want to ablate them, you really should only do that if you know how to perform endoscopic resection. You send the specimen to the pathologist, and they can tell you what type of tumor it is. So if it's a low-risk mucosal cancer, so well to moderately differentiated, no lymphovascular invasion, if you removed it radically, these are very good cases for endoscopic management. If it's a high-risk cancer, T1A, so still mucosal but with poor differentiation and or lymphovascular invasion, we advise oncological staging. So that's a EUS and a PET-CT or CT scan. If there's no signs of lymph node or distant metastasis, then the guideline says that you can consider a strict endoscopic follow-up with gastroscopy and EUS, or treat the patient additionally, which means surgery and or chemoradiotherapy, or a combination of those, but really on an individual basis. If the pathologist tells you that you have removed a low-risk submucosal cancer, so that means superficial submucosal invasion up to 500 microns, well to moderately differentiated and without lymphovascular invasion, again, we advise oncological staging. But then if there's no metastasis, the guideline recommends strict endoscopic follow-up is sufficient. And if there's a high-risk T1B cancer, so with submucosal invasion beyond 500 microns, poor differentiation and or lymphovascular invasion, we advise the same as for the high-risk mucosal cancers, oncological staging, and then decide on further treatment on an individual basis where endoscopic follow-up is also an option. And how did we get to these recommendations? Well, this all evolves around the risk of lymph node metastasis, of course, because EMR or ESD is only local treatment. So for the mucosal cancers with low risk, we know that the risk of lymph node metastasis is extremely low. So it also doesn't justify staging. You can just treat them endoscopically. For the high-risk mucosal cancer patients, we don't have a lot of data. Most data that we have is retrospective. But from the studies we have, we know that the risk of lymph node metastasis is much higher than we actually thought. So it's somewhere up to 20%. So in our vision, this is not enough to justify surgery in all cases, but you should do oncological staging and discuss these patients in an MDT. Low risks of mucosal cancers. We do have quite some data, mainly based on endoscopic series, and we know that the risk of lymph node metastasis in this group also is relatively low, around 2%. So we do advise oncological staging, but really think that endoscopic strict follow-up is justified. And then the high-risk T1B cancers, they have quite a, well, increased risk of lymph node metastasis, but most of the data comes from surgical studies that have a lot of limitations. And we have some endoscopic studies, but most of those studies are still small and retrospective. But based on what we know, we also think oncological staging and then decision on an individual basis would be good. And I think this slide really is sort of a highlight of the guideline, because this is one of the first, or it is the first guideline advising really on these different subtypes of cancer with well, literature based. And it's really, well, I think ahead of other guidelines on early cancer. And I also want to stress that if you have these patients, you should only follow them if you have all the good facilities for EUS, FNA, and an MDT to discuss these patients and treat them if they turn out to have lymph node metastasis. So once you have resected the lesion and you have no contraindications for further endoscopic treatment, we know that there is a risk of recurrent neoplasia in the remainder of the Barrett's within 5 years. So we recommend offering complete eradication of all remaining Barrett epithelium after endoscopic resection of visible abnormalities with dysplasia or adenocarcinoma. So I'm not going to discuss why, because there's a lot of data presented already on this subject, but I do wanted to shortly mention follow-up after endoscopic eradication therapy, because that's also something new in this guideline. I think it's really important to mention that if you follow these patients, endoscopic inspection is really the most important. Thorough endoscopic inspection of the Barrett segment, ultra and retroflex position, use high definition white light endoscopy and virtual chromo endoscopy, because that will help you detect these small residual islands that you can then touch up with APC. We know from our Dutch registry that most of the recurrences, or all the recurrences we had, were all found as visible lesions. The random biopsies we took during follow-up did not add to the detection of recurrent neoplasia. 38 were found at the cardia without real Barrett's, and 62 in the tubular esophagus with small residual or recurrent Barrett segments or small Barrett islands. So inspection is key. You don't have to take biopsies from the neosquamous epithelium. We do advise biopsies just distal to a normal squamous junction to detect dysplasia. In expert centers that can be abandoned, but this is just an area that is difficult to inspect, as you see in the picture. So taking biopsies here to exclude dysplasia is still advised. And of course, if you have abnormalities in the tubular esophagus. And we advise the following intervals and after endoscopic eradication therapy. So for high-grade dysplasia or cancer, we advise it yearly during the first 5 years, then at 7 and 10 years after treatment, and then you can stop. And if patients had baseline low-grade dysplasia, we advise follow-up at 1, 3, and 5 years. And then you can stop if there's no recurrence. And again, there's no exact age cutoff, but we know that patients are also likely to die from other causes than recurrent esophageal cancer. So if you follow these patients, not only look at age, but also take into account the whole patient and discuss with them the benefits of follow-up and finding recurrent Barrett's or recurrent neoplasia and weigh that against competing health concerns. And that's what I had to share about the management part of the guideline. So thank you very much.
Thank you, Roos. Wonderful presentation. Yeah, now we have time for a couple of questions, and indeed our participants are very active answering questions. So we have, yeah, I would say 15 minutes. Let's start with the first questions for mainly for Bart, I think, for diagnosis. So Bart, the first question was, could be a large hiatus hernia a risk factor for Barrett's esophagus?
So the question is if a hiatal hernia, a large hiatal hernia, is a
Yeah.
risk factor for Barrett's esophagus.
Yeah.
I would say yes, because most of the patients we see with Barrett's neoplasia do have hiatal hernia, but it's not a condition sine qua non, so to speak. So you can have long Barrett segments without an hiatal hernia, and you can have a large hiatal hernias without Barrett's esophagus. But yes, there is an association between reflux disease and hiatal hernia, and per definition, also between Barrett's esophagus and hiatal hernia.
If you do the Seattle biopsy protocol, do you put all the biopsies in one glass or separate every centimeter? I mean, you biopsies areas where you don't really see nothing. So the question is important to save money and make endoscopy green. Can we?
Yes, we discussed it. That's nice. Nice question. We discussed it. Well, the recommendation is to do 4 biopsies per segment of 2 centimeters of Barrett's and put those 4 biopsies in one jar and do the next segment. But we had a discussion indeed whether it would be justified to put all biopsies in one jar, one container, and thereby saving money and also pollution, etc. But we thought that it would be helpful to have some insight if you detect dysplasia, especially in longer Barrett's, where you have to look and scrutinize the esophagus if you detect dysplasia on random biopsies. So the advice is to do it in separate containers, so 4 biopsies in one container.
And maybe one question from my side. You mentioned the inspection time, 1 minute for 1 centimeter. To my knowledge, this is only confirmed or was published in one paper from Pratik Sharma. Do you think we need more evidence for this? I mean, for the colon, we know the withdrawal time, and there are dozens of papers who confirm this. Now we have this paper. Everybody recommends it in the guidelines, and I'm a bit scared because when this paper was published, we still used the Seattle biopsy protocol. We had different endoscopes. Now I'm wondering, either we should no longer use the Seattle biopsy protocol and increase inspection time, or something should be changed. We cannot add time, and is this really the right way to inspect the Barrett and to biopsy? Can we reduce the biopsies if we inspect 10 minutes, 1 minute per centimeter?
Yes, that of course is the key question, and it's funny that you mentioned the scientific basis of the recommendation of the 1 minute inspection time, and that is, as you mentioned, it's very weak. The issue here is that we would like to emphasize that it's important to spend enough time in the esophagus.
Yeah, that's true.
And if you do a proper examination, if you do it with white light and vertical endoscopy, then you easily spend 1 minute per centimeter of Barrett. So that's not an effort. It's just a way of saying that we need to spend time in the esophagus. There are believers in that we could get rid of those sagittal biopsies, and I must say I'm not a believer, because I think I spent a lot of time in the esophagus, and I think I have quite some experience in detecting lesions, but still I encounter patients with no visible abnormalities with the best endoscopes we have with vertical endoscopy, and still they show low-grade dysplasia in biopsies. That is not a very rare situation, and that really influences the risk and also thereby the interval of surveillance and even treatment. So I don't think we are there yet to abandon random biopsies.
Okay.
But that's my personal opinion, and maybe Roos thinks
You're
differently about it, or you?
You believe in the Seattle biopsy protocol. Honestly, I'm not. I try to avoid it. I inspect longer. I use acetic acid. And another question is, should we use a distal cap? Is this helpful? Or the data that a cap is useful, similar in the colon?
I am personally not aware of studies on using a cap. so I don't think there are studies.
I don't
It
know.
it is for sure helpful in the area of the esophagogastric junction, because there you have the gastric folds, which are, it's very helpful to spread those folds and look at that area. It's less helpful in a long Barrett segment, a long straight tubular Barrett's. And it adds considerably to the costs. One cap in the Netherlands is about 25 euros, which is not, and the risk of dysplasia in a regular Barrett's surveillance is relatively low. So I don't think it's cost effective. But if I get a referral with dysplasia, I always use a cap.
Okay. Another question, maybe, Roos, if you have a small ulcer at the GU junction in a short segment Barrett's and the biopsy showed low-grade dysplasia, what is your management?
If it's a small ulcer?
Small ulcer?
Yeah.
And you biopsy low-grade dysplasia, what would you do? A second opinion for the pathologist, okay? And then?
Yeah, so that, but I think if there's an ulcer, so it's sort of a visible lesion, you don't really know if it's really due to reflux, if there's really neoplasia causing the ulcer. So in those cases, we normally would just talk to the patient that they have to take their PPIs or increase their PPIs and repeat endoscopy after 6 to 8 weeks with a very low threshold of doing an EMR if there's still a lesion. So sometimes, like if there's really a deep ulcer or an erosion, that's a different, but I would have a low threshold of doing an EMR if you have to do the re-inspection and there's still something visible. If it has completely healed, you could repeat the biopsies, but I think those are sometimes difficult cases, especially in patients with big hernias. They have these ulcerations, but I would not discard it as, oh, it's just low-grade dysplasia. We'll see them back in 6 months.
Yes, exactly. Because you showed this case with reflux, and then there was a small lesion, maybe bulky lesion. It looked very hard. So what's about if you don't see anything? You have just reflux, you have a long segment Barrett. What is your recommendation in this situation?
Well, reflex esophagitis grade A or B it will allow you to do a proper inspection and also will allow you to do the random biopsies. If it's reflex esophagitis grade C or D, the recommendation is to increase the anti-reflux therapy, by what means that's up to you, and then repeat the endoscopy at 6 weeks or 8. But I showed this case just to mention that just seeing reflex esophagitis doesn't mean that you have to shut off your brain. You should keep thinking and you should keep looking.
Yeah, that was a nice case, a nice daily practice case, I would say. We have the same situation.
It was really a daily practice case.
Yeah, I believe. Roos, T1A mucosal M3 cancer, what is the risk of lymph node metastasis? And is R0 resection enough in this situation?
So if it's M3 without risk factors,
M3?
moderately differentiated without lymphovascular innervation, then the risk is really low. It's less than 1%. We have a lot of good high quality data on that. So you don't need any additional staging or treatment, just endoscopic treatment.
Yeah, but by the way, what is the mortality risk for surgery in your country? I mean, in Germany, we have esophageal cancer centers, and there is indeed, we document the mortality. And what is in your country, the border, the limit, and how many cases needs a center treated surgically?
So the risk of mortality is 0 to 4%. In the Netherlands, and it's centralized. And I think it's now 20 for esophageal and for gastric, but we're moving to new guidelines, which will state expert centers doing surgical resections need at least 75 cases, of which 25 can be endoscopic. So the numbers are really increasing because there's a lot of data on better outcomes in high volume centers.
This is almost the same in Germany. So around about 2 to 3% of mortality and the numbers for high volume centers is now also increased. So you need at least 30 cases or so. Yeah, that's, I think, important. Bas, a second pathologist, can this pathologist from the same department or somewhere else?
Well, the problem of pathologists in your own department is that they are probably looking at the same way to the biopsy specimen because they influence each other. So ideally, you should send it to an independent, experienced pathologist, but that's not always practical. And I think it depends on the situation you're in. But preferably, it should be a recognized, experienced pathologist.
Roos, when you perform an ablation, when do you continue with surveillance? How long should we wait?
After you've done
after ablation? Yeah.
So normally we see, if you have done an ablation, we see the patients back after about 3 to 4 months to see if everything has healed. And we repeat the ablations until we have endoscopic eradication of the Barrett's. And once we have reached that, then we see them back after 1 year.
Okay.
And
so
then
there is an
then
there is an interesting
data every
comment. Okay.
Yeah.
Sorry. An interesting comment from a colleague in Peru. So we have participants in South America as well. And the comment is that in Peru, obviously, 50% of Barrett neoplasia are in women. And do we see a similar increase in female in Europe? Are you know about any data? I mean, so far, it's 90% male. In my clinic, maybe it's selected cases, but what is your experience? Are females more affected with Barrett's neoplasia?
I have to say that I don't have the exact data. We do see more men than women.
Yeah, definitely.
But I don't know if
it
has been
didn't change for me. So my gut feeling tells me more male, no? More men. Yeah. Okay.
80% is male in my practice.
Yeah.
And I don't see any, but I don't see a trend, but I don't have the data. But it's nice. It's worth looking into that.
Yeah.
And it's fascinating that 50% in Peru is female, or 60 or 50. That surprises me.
50% is high. Another important question is, what about downstaging of low-grade dysplasia by the pathologist? How often do we see this?
So from low-grade to no dysplasia? Yeah, it's about like in 2/3 of the cases. So about a third is confirmed, but the majority in number of studies, but the majority is really downstaged. And we know that these patients really have a risk of progression as patients who don't have dysplasia in their Barrett's esophagus.
And in a patient where you have low-grade dysplasia, which is confirmed by a pathologist, would you do a second endoscopy or would you go straight forward to ablation if there's nothing visible?
No, so we really advise to have 2 endoscopies with low-grade dysplasia, because we know that the progression risk increases if you have dysplasia, low-grade dysplasia, separate endoscopies. And also there's about a third of the patients who don't have low-grade dysplasia at follow-up endoscopy. So you would overtreat those patients. And I think doing a second endoscopy also will allow you to pick up neoplastic lesions if there's progression. So I really would not rush into treatment for one diagnosis of low-grade, even if it's confirmed. We know that you can very safely follow these patients after 6 months.
Another question on R0 resection in a submucosal cancer when it was resected by piecemeal. Is this a R0 resection if you have piecemeal resection in a submucosal cancer? How should we define this?
Yeah, if it's R0 in a piecemeal resection and you have a nice endoscopic radical resection as well, yeah, it's an R0 resection. We have a lot of.
I think if the lesion is just in one piece, no, and the pathologist confirms in this piece is R0 and the rest was maybe Barrett and with low grade, then I would say this is treated adequately. But if you have several pieces with cancer, that might be debatable whether the treatment was ideal. And I think that the guideline recommend then doing ESD is maybe the treatment of choice.
Yeah, but I do think there's not like there's I think that's a still ongoing debate because we have been doing piecemeal EMRs for these lesions for a very long time, for years, with very excellent outcomes. And of course, we have constant techniques, so we can do more and more. But Bas is actually doing a nice randomized study on the topic.
Yeah.
So the next webinar, we will have an answer maybe.
Okay. Then after resection, if you have a stenosis, do you dilate to and perform RFA in one session?
Yeah, so it can be done. It depends a little bit on how tough the stricture is, and if the patient has complaints or not. So you can do dilation and RFA in one session. But I think in those cases, it really depends on how severe the stricture is. And also if you expect the stricture to worsen if you do RFA, because then you should consider just keeping the patient under surveillance, for example.
And if you have a patient with Barrett neoplasia and you perform endoscopic ultrasound, let's say, and you see some lymph nodes, is this something which needs to be biopsied by FNA, or you would straight send forward to surgery, or would you resect and then wait for the definitive histopathology and to decide whether this lymph node is reactive or is malignant?
You mean prior to endoscopic resection?
Yeah.
Right. I think so. We don't do staging before we do EMR, but if you would have an indication to do it before and you see a suspicious node, then I would puncture it, but only if if you have to puncture through the tumor, of course, you should not do it. I would also do a CT scan in those patients to see if how suspicious the nodes are, and I think it's a more complicated answer, really depending on a lot of issues.
Yeah, and if I might add, an important issue here is if you do an EOS for a low-risk cancer, and if you see endoscopically a low-risk cancer, then you can run into trouble, because then you can have a reactive lymph node, which is not related. Then you puncture through a dysplastic Barrett's epithelium, you see dysplastic cells in your punctate. So you should only do EOS or staging if you have endoscopic reasons to be suspicious of advanced cancer.
Yeah. So honestly, I never performed the US FNA in a Barrett neoplasia with enlarged lymph nodes.
No. So then you should go for a CT or a PET CT if you really have got suspicion.
As one comment on the Bing classification, is it helpful?
That's also a difficult question. Well,
Bas,
what is help?
Bas, be careful with the answer. I was one of the co-authors of this paper.
Yes, I know. What is helpful is to have a sort of structured way of looking at Barrett's. And if you use the Bing or the Blink or whatever, you should look to the mucosal pattern and to the vascular pattern. And using the Bing classification can help in that.
Okay. And another question.
Is it a satisfying answer for you, Helmut?
For me, it's okay.
Okay, fine.
But another question to you about cytosponge. We don't use it in Germany. I don't know anybody. Have you any experience? I mean, Rebecca Fitzgerald did great studies, and what about the costs? I mean, you mentioned cost effectiveness for screening. Is cytosponge what are the costs for cytosponge and this cytopathology?
I have no personal experience as well, but what I learned from Rebecca is that the cost of a cytosponge, including the assessment and the biomarkers, is half of endoscopy.
Oh, really? Okay.
Yeah. And Roos, I know you are doing or thinking of a study with cytosponge. Did it already start?
is it commercial available anywhere in Europe? I don't know, honestly.
I don't know either, I have to say. So we have a study ongoing, but it's
Yeah,
all in,
okay.
so
Okay.
it's in study setting.
Okay, okay.
I don't know about
The
the
UK is Europe, right?
Okay.
EU.
We should, yeah, we have
EU, okay.
EU. And another question is, did you see a Barrett esophagus after sleeve gastrectomy? Or must be very
Well,
rare.
a sleeve gastrectomy is a risk factor for reflux.
Yeah.
And it's well known to the bariatric surgeons that if patient has reflux symptoms, they shouldn't do a sleeve gastrectomy, but they should do a gastric bypass. So I don't think there are data, but there are data on reflux post sleeve gastrectomy. So I would say, yes, it's a risk factor.
Maybe a couple of questions, then we stop here. Otherwise, I told you 2030, I have to watch a football game. So, but there are still more than 330 participants waiting for answers on their questions. Roos, a short comment on a Barrett glands if you ablate. Is it an issue? Is it a problem? How should we surveil patients taking biopsies from squamous epithelium? What is your recommendation in this field?
Barrett glands? Buried glands, yeah.
Barrett glands.
I think, yeah, the buried Barretts, yeah. I don't think it's because I don't think it's a real issue. We haven't found any buried Barretts, or just 0.01% in over thousands of biopsies we've taken. So we really advise against taking neosquamous biopsies after RFA because it's time-consuming, also for the pathologist, and it's expensive and not very good for our environment because the yield is extremely low. And the most important thing is just to do very good endoscopic inspection. We know that there have been case reports on buried Barretts. The question is, were they really buried or small Barrett islands? But they eventually, you can see them as a sort of a submucosal bulge or area where the mucosa is a little bit different of color. And then you can take a targeted biopsy of those lesions. So inspection.
Inspection.
Yeah.
We indeed published a case report. There are indeed only cases now where you see a bulging lesion and then beneath the squamous epithelium, then obviously there were some Barrett glands, and this is can be cancer. I think you shouldn't be worried about much. Last questions now. Any indication for a patient with Barrett but no dysplasia? Did you ever ablate a patient? Let's say we have a 30-year-old male, 10 centimeter Barrett, and his father died of Barrett's esophagus, and he is afraid of dying on Barrett. Would you ablate this patient?
I would personally, I would not ablate this patient. I would advise maybe on a fundoplication or something to adequately treat this reflux disease. But I would discuss with the patient that, especially if it's 10 centimeters, ablation is quite extensive. And if you keep them under very strict follow-up, I think you would detect neoplasia.
Are there any data that a gastroscopy for diagnosis of Barrett or surveillance is better in sedation bars? We have data in screening colonoscopy that sedation makes sense to increase the RDR.
There are some data. It's not very solid data, but there are some data that well, of course it's a little bit of a mixture because sedated patients, I must say it otherwise. We did a study comparing dedicated Barrett's lists compared to non-dedicated Barrett's list, and in the non-dedicated Barrett's list, patients were most likely not to have sedation. In a dedicated Barrett's list, they were sedated. So and the yield of dysplasia was much higher in the dedicated lists. So also in the sedated list. So it's a little bit difficult to know what is what, but it simply makes sense. if you have a patient which is gagging and restless, and you cannot do a proper inspection, it's impossible. Of course, there are exceptions to the rule, and some patients really tolerate unsedated endoscopies very well. And of course, there's no reason to sedate those patients, but the majority of patients, I'm convinced that the quality of the surveillance endoscopy is much higher if you sedate them properly.
So two last questions, one for each, and then we have to stop because there are still questions coming in. Steroids after ablation or resection, what do you recommend, Roos? When should patients be treated with steroids to avoid strictures?
Yeah, so after ablation, we know the risk of strictures is low, it's around 12%, so we don't give steroids. We do give patients steroids if we have done a circumferential ESD or EMR, where we know that the risk of stenosis is almost 100%, and then we give them prednisone. 40 milligrams.
Which dose? For local application like EOE, or is systemic?
No, we give them systemic steroids, 40 milligrams for a week, and then taper it.
Yeah, it's the same as we do it.
Yes, and I personally only rarely give systemic steroids, and I tend to give local steroids. And I don't think there are good comparing data between those two approaches.
And if we had now a Japanese expert here, they would inject steroids in the resection area. And the last question, maybe, Bas, if you have a patient with a long segment Barrett, he has no reflux, how to prevent cancer? Is PPI necessary? Or would you recommend pH-metry? And because many patients with Barrett don't have any reflux symptoms, but if you measure with pH-metry, what is your recommendation?
Well, there is a recommendation in the guideline, and the guideline recommends regular dose PPI for a chemo prevention, so to speak. It is difficult to have very solid data on that, but there are several studies suggesting that it decreases the risk of progression to cancer. I don't think that pH monitoring is helpful because we know those are reflux patients, because otherwise they wouldn't have Barrett's. And it is not proven at all that you should aim your dosing of your PPI based on pH monitoring. So the recommendation is single dose PPI or PPI needed to treat symptoms. If you are symptomatic on one dose PPI, then you should increase it.
But for an asymptomatic Barrett's patient, PPI?
Still, the recommendation is still to give them PPI. Although not very solid based, but that's the recommendation.
Dependent on the length of Barrett, what would you say if you have 2 centimeters, 10 centimeters? This is a question we had also a long debate in the German guidelines, and actually, my opinion was to measure the reflux, because we measure the blood pressure and treat patients according to the blood pressure. Why not measuring with pH-metry to say, well, he has reflux, but he doesn't have any symptoms. So this is my concern, that we oversee a lot of patients or we overtreat other patients. But as you said, lacking data, no?
Yes, it makes sense if we would have data to taper the dose or to justify PPI in longer segment Barrett's, but we don't have data on that. And there is some evidence that there is risk progression, reduction of risk progression after acid reflux control.
Great. I think we stop here right now. You have answered so many questions, almost 50 questions. Great answers. Thank you so much. Thank you for presenting the brand new guideline. And for those who have questions, you can see the guidelines on the web page of our Society of ESGE. Thank you both for the guideline work. It's always a tough work, and having the first and the last author here was a privilege. Thank you both. Yeah, and then I would like to thank our participants. It was really a very nice kickoff with many hundred participants. And this year is a special year for ESGE. So I demonstrate you the ESGE Diamond Jubilee. And you see Thierry Ponchon, one of our past presidents. I mean, he initiated ESGE Days, and he is committee chair of our Jubilee Committee, and there are many, many activities. So please visit our website for more details. And maybe the next slide. And I hope you all have this date in your diary. So please join us in Berlin. Last year we were more than 3,000 participants in Dublin. Was a fantastic meeting, and we expect more than 4,000, maybe 5,000 participants in Berlin. Now there's another deadline for the Innovation of the Year award. It's approaching 1st of February. So again, look in the website. And for those who are not members of our society, we are an increasing society. We are a young society. The average age goes down despite I'm getting older. We are more and more female. We have rising stars like Roos. So and everybody is encouraged to join ESGE. So please have a visit and become member and join ESGE Days in Berlin. And at the very end, yeah, this is the next webinar, 7th of February, about POEM and motility disorders in esophagus and gastric. So Dr. Roberta Marcelli from Milan, Jan Martinek from Prague, and Sandra Nagel from my unit will present data in this field. So happy if you join this meeting, and then I wish everybody a nice evening. Enjoy, and hope to see you soon. And once again, thank you, Roos. Thank you, Bas. Bye-bye.
Thank you, Helmut.
And a great thank you to Gabi and David, who worked in the background that everything runs so smoothly. So thank you. Bye.
Bye-bye.
Bye-bye.